have one additional member of the panel to be sworn in.
Please state your full name
Theresa Marteau.
and repeat after me. I do solemnly, sincerely,
I do solemnly, sincerely,
and truly declare and affirm
and truly declare and affirm
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
So we were looking before lunch at the question of stigma for those suffering from HIV. And before we leave the topic of stigma, I wanted to look at one of the materials you've referred to in your report relating to stigma and hepatitis C. Henry, could we have up, please, on screen EXPG 5028, please? This is a 2017 paper by Northrop headed A Dirty Little Secret, Stigma, Shame and Hepatitis C in the Health Setting. And if we just look down the bottom of the left-hand column, please, on that page, under the heading Introduction, 4 lines in, illnesses tainted by the stigma of questionable lifestyles present specific challenges, particularly in health settings when treatments are sought. Hepatitis C provides one such example. Within the high-income world, the hepatitis C virus, replete with connotations of illicit behaviour and self-infliction, is most commonly associated with injecting drug use, IDU. And then the paper goes on to talk about an Australian study with individuals, none of whom had engaged in injecting drug use. And it says this at the bottom of that column: despite this, the association between HCV and IDU was found to be highly problematic, impacting all aspects of life, personal relationships, employment opportunities, and significantly in this instance, access to health services. Because hepatitis C is often concealable, the decision to disclose one's blood status and to whom emerged is a centrally important consideration. Participant accounts underline shame, stigmatisation, fears of potential stigmatisation, and extreme caution around disclosure. And then it refers to, in keeping with subsequent research, health settings emerged as one of the most vulnerable sites for experiencing stigma. This paper goes on to narrate various experiences very similar to the experiences described by witnesses to the inquiry, so I won't dwell upon the detail of the paper. But this exemplifies the continuing stigma associated to this day with hepatitis C. Is that fair? Can I ask someone to answer, because the transcript doesn't pick up a nod?
Yes. Yes, as we know, hepatitis C is more prevalent than HIV, and it's still associated with some stigma. Yes.
And it's very much for similar reasons to those you discussed before lunch. It's that question of seeing certain types of behaviour associated with it that is seen as bad by society, and then the aspects of fear that you described earlier.
Yes, both as you say, the shame from seen to be associated, the sort of stereotype of deviant behaviour, plus fear that you might contract it.
And the way you put it in your report was to say that hepatitis C as a stigmatised condition shares some characteristics of HIV with its normal route of transmission through handling blood, particularly in the context of illicit drug use, linking it with publicly acceptable behaviour. And then you go on to say this: the main difference was that no major educational campaigns specifically targeted hepatitis C. The public therefore had very limited knowledge about hepatitis C, and they therefore drew on their knowledge of HIV, which they thought would be very similar, and this frightened them.
Yes, several people said that explicitly. Well, I don't really know, but I think it's a bit like HIV, and then had their image of HIV.
Can I say one thing, is that underlying this, of course, is the society that we live in that has such a judgment. And I suppose from a nursing perspective, you know, when you're a nurse, you don't make judgments about why people are sick. And I think we live in this society where we make judgments about people's behaviour with sometimes a very poor empathy and a poor understanding of what got them into that position, and whether that be drug users, whether that be anything else. And I think the stigma that we're talking about, you know, it hasn't just arrived, we make that stigma. You know, we've created this society. And I think it's a really important thing, and especially with this article, which talks about stigma within the healthcare service, and about whatever reason that you go into the healthcare service, you should be cared for as a human being, and not be judged for whatever behaviour you're there for. But that comes from a very nursing perspective, which I think we need to have as nurses.
Witnesses have commented on and relayed, and you've picked up on this in the report, a number of different ways in which they have experienced stigma, at least felt stigma, if not enacted stigma, within healthcare settings. And I just wanted to explore a little the potential consequences of that. That can be obviously distressing and upsetting for the patient, but it can presumably have a longer-term impact in terms of engagement with clinicians, trusting clinicians and healthcare providers, adherence to treatment and matters such as that.
Yeah, very strikingly. I think we could see that, and that's consistent with research. I think when people lose faith in a system, lose that sense of trust, then there are two things likely to happen. Either they will try and avoid, work their way around different parts of the system, and there's a paper that we talked about, Following Medical Errors, how people try to navigate their way around the bits of the system that they've been offended by. Or people go into slightly more passive, sort of resign, well, there's nothing I can do, you know, and feel that somehow, again, the blame gets internalized. You know, well, clearly, you know, I've got something that they really don't want to be bothering with. So I think, you know, there are a number of ways in which that can happen. And I think it was interesting before the break you talked about that was then, this is now. Well, I just a couple of weeks ago read a study on looking at a large trial in America where they were offering PrEP, which is, you know, a treatment for the prevention of HIV and AIDS, to a large, you know, relatively socially excluded population. It was a very large study from Chicago. And the study that the uptake of PrEP was low, and they started to look at it thinking it was going to be this excluded group. And it wasn't. It was the failure of family doctors to really recommend it. And some actually said out loud things like, well, you know, I'm not sure, you know, it's right to encourage, you know, the sort of behaviour this is going to allow people to have, i.e., you know, more frequent sexual contact and so on. So, again, and that's, you know, a 2019 paper. So there's still a lot of big issues out there in terms of, you know, judgment that's being made by healthcare professionals, negative judgment.
And specifically within the healthcare setting, are there any suggestions that you can make, either now or if not now, perhaps in the supplemental report that you're kindly undertaking to provide, about how stigma within a healthcare setting could be addressed? If it's something you would like to think about and reflect on and put in the report, that's
so.
fine, but it's obviously an important
Unless anybody
topic
got
of
any
inquiry.
immediate?
The only immediate thing that I can mention is the fact that if you actually associate different groups of people with things, prejudices, what we're talking about here, they are so ingrained over years and years, and it doesn't matter which professional group you belong to, we all have different prejudices that sometimes are very overt, other times they're hidden. And I think they're very difficult to change. They're very, very difficult to change. And you can do all sorts of online surveys to see how ageist you are, how racist you are. And even if we think, oh, I'm not ageist, I like old people as much as young people, I'm not racist, I like Asian people as much as, you know, sort of Caucasian people, you do some of these surveys and you see how subliminally you've got a lot of these features yourself. So all I'm trying to say is that it's very difficult to help people change behaviours that they have developed over years or attitudes that they have developed over years belief systems, about certain groups, being less honourable or less reliable than others, all these sorts of things. They're difficult to shift.
There is a move, I think, within perhaps the NHS, but in other areas, to address racism with unconscious bias training, where rather than sending people on a diversity training, which everybody hates to go on and doesn't think it applies to them, if people are helped to understand their unconscious bias, because we all have it, every single person in this room has it, towards the other. And it's about recognising that when we see people as the other, that we have that unconscious bias, which then leads to stigma or discrimination. And I think that's for me, that would be one direction that we could think about in relation to something like this, because I agree with Sian that as healthcare professionals, we should behave in a certain way. And one thinks, well, why did you go into the healthcare profession and the helping profession if you're going to behave in a way that isn't helpful? But we also have other contexts in which we live our lives. So we've already discussed the idea of religion and faith. And there will be many healthcare professionals who hold a very strong position because of their faith. We have positions according to our ethnicity. There's many contexts, whether we're a mother or father, as to how we react to people. And if we don't reflect on that, then we never change it. And I would say that one of the things that I think changes healthcare professionals the most is the opportunity to have supervision, good supervision. And right now, medical doctors don't get supervision, and nurses very rarely get supervision. The people who get the most supervision are psychologists, who spend their whole life talking to people and then talking to people about what they've talked to people about. But
We like talking.
yeah, as you can see. But that then means that we have an opportunity to reflect on what we said, and was that hurtful? Was that the right thing to have said? And should we do that the same way the next time we're in an interaction with somebody? So I think that would be a very good and not simple, but it would be a good start to get people to have some greater degree of reflective practice.
And then, Theresa, sorry.
So I was just going to add to what's already been said, to say that people working in the healthcare system are part of society, and so our prejudices will be revealed through the people working in the health service. So I think it points to two targets for change. One is society more broadly, and perhaps where there would be faster change would be, as has already been said, unconscious bias training, which as a university teacher I undergo. It's very important in terms of recruiting students to university as well as in teaching. So it is possible. I don't know what happens in the NHS, but I would have thought that this would be an absolutely core part of effective and sensitive communication training, which I presume we will be coming on to.
We will in just a moment. Dr. Thomas, was there something you wanted to say?
Just to add to what everybody just said, that communication training is a really important way of helping people, but involving key participants who are, if you like, hepatitis C sufferers, to be part of that training program, so that they are communicating that experience at first hand. And from my experience of working in another area, it's a really powerful message that you're sitting there and you're actually saying this is how you make me feel. And those exchanges are really helpful to get people to think about their biases and to think about how they might change.
Before we just move on to what is going to be, I think, another topic, can I ask you, when you do consider this question in a supplementary report, you address a couple of things. One is that it's been suggested earlier, and it's been suggested by a number of people, that the answer to a lot of bias, a lot of prejudice, a lot of stigma is education. That presumably is education about the disease, its natural progress, how you get it, what it is, therefore replacing ignorance with information. That is particularly, it is particularly therefore worrying, perhaps, that some of those who are currently in the health service are suffering stigma when they ought to be the most informed. Does that in any way invalidate or cast any doubt upon education as such, on its own, being an answer? And secondly, if the NHS is a caring profession which ought to be fully educated, how best do we prevent the societal, it's not, I think, an answer to say society is stigmatizers, because it may be, might it, that people in society have their attitudes affirmed because they know somebody who works in a hospital who has exactly the same attitude. Yes. And so there may be an element of cross-affirmation going on, which affirms prejudice or stigma as it's perceived, and is therefore unhelpful. And a way, at least, of addressing society's stigmatizing might be to start with the health service. But it's a suggestion which you might want to consider, and the pros and cons of it is just a thought which has occurred to me as I've listened to you.
And we'll write to you and set that out. You don't need to try and remember it. I want to move to the question of communication, which a number of you have alluded to in your answers already. In the report, you say this: good quality communication is an essential element of healthcare practice. And I wondered if you could just elaborate upon why that is the case. Yes, I'm looking at you.
Yes, good quality communication is absolutely pivotal to everything that happens within medicine. Because if you are a poor communicator, you're probably a poor listener as well. So you don't hear what patients say. You don't actually ask questions in ways that permit them to be accurate givers of their history. You probably don't communicate well with your colleagues either. And all healthcare now is a serious team business. The days of, a patient going and seeing one individual who then offers a prescription and everything sort of is all hunky-dory are long over. People are treated within teams. And so good communication lies at the heart of absolutely everything that is done within healthcare. And sadly, it's one of the areas of health education that probably receives scant training. In the course of a clinical career spanning, if they're lucky, about 40 years, the average consultant within a hospital will have 240,000 interviews at least with patients, which is more times than they'll do anything else in their career. It's more times than they'll wield a scalpel, take a blood pressure, feel a pulse. Yet if you contrast the amount of time that is given over to practical skills in most of our medical schools with the amount of time given to communication skills training, it's easy to see why we have a major problem.
And we've obviously had examples that go back to the 1970s through the 1980s to the present day. And from what you say, Dame Lesley, it sounds as though from your perspective, it is still very much a present day problem.
Yes, it is. Although certainly within most of our medical schools, there has been an increase, and also schools of nursing, in communication skills training. Very often, even the format of the training is poor. You cannot possibly, rather as Nicky was just saying, you can't possibly learn an experiential skill such as communicating merely by reading a book about it or listening to a lecture. And yet that's still how a lot of our communication skills training is done. You have to do it. You have to have feedback from experienced facilitators, from patients themselves, if you're going to actually change the way you communicate in beneficial ways.
One of the papers that you've referred to, I don't need to put it up on screen, but if anyone wants to know where to find it, it's EXPG 5016, and it's a paper by Elder, 2017, and it talks about empathy and the importance of empathy in the clinician-patient relationship. Again, many of the statements that we have received describe a lack of empathy. Yes. What role does that play in modern medicine, and is that something that can be taught or assisted?
That's a very interesting question, because there are lots of debates that go on about whether or not you can actually teach people to feel, to care, to walk in the same shoes as the person in front of them. That's what empathy is about. And if you don't naturally possess those sorts of feelings as an individual, is it actually possible to teach it to people? I suspect it's difficult to teach empathy to people who are just, their personality disposition is that they are not empathic. However, one can teach them skills of conveying at least a sense of empathy when they're dealing with people. It's all in the nuance of the way you say things. You can always manage to say something that sounds callous and indifferent, or you can actually say precisely the same words, but say them with a sort of empathy that is conveyed by either their non-verbal facial movements. The fact that people even look at you when they're talking to you conveys, hey, I'm listening to you. I feel what you're actually saying is really an important problem for you. And there's a very interesting paper that I read a few years ago that I give medical students and other healthcare professionals who come on training courses. And it's called You, Me, and the Computer Makes Three. Because a lot of interaction now that takes place within our sort of, GP surgeries as well as at hospitals is with somebody in front of a computer typing things up. And that's when you also lose all the, key non-verbals, and it looks as though somebody doesn't care if they're just looking at their computer.
Dr. Thomas.
Yes, and the flip side of empathy is compassion, and there's quite a lot of work being done at the moment within the NHS to try and instill more compassionate healthcare professionals. And an important element of that is enabling people to actually have feedback about their skills. And I think together, hopefully, those methods down the line will impact. But the transcripts were really clear that some of the experiences that people have had has been really unempathic and definitely without compassion.
Do you know, any of you, Dame Lesley, you may know the answer to this, I hope, but any others who may assist, to what extent is any of this communication skills training, work on compassion and empathy, part of any of the basic medical training that the medical schools deliver as part of a degree?
Most curricula do have some of that within it. As I've said before, though, I think very often the methods that are used are not always the most appropriate. And also the time that is devoted to it is just pathetic, really. And I, one of the things I think that is important is that, and this actually I think is particularly pertinent as modern medicine becomes more and more complex, is that you can meet very good communicators who appear very empathic and, sort of have the patient's needs right up front there. But they become so inured to the terminology that is used within the health service that they might just as well be talking Chinese to the person in front of them. And one of the other skills that I think we need to help people develop is how to put complex information into easy layman's terms without being patronising, because people are not giving informed consent to tests or treatments if they haven't actually understood a word of what somebody's been saying, no matter how kind, compassionate or empathic they might appear.
There's a, can I was going to say,
Yes, absolutely.
There's a very recent paper that's just come out which has been very important in diabetes care, which is called Language Matters. And those of you that are Twitter followers can read all about it on hashtag Language Matters, and it tells you, and it's really about the kind of words that you use when you are thinking about somebody, when you are communicating with somebody, and it's a really powerful document that the diabetes world is trying to get everybody that's providing care for the thousands and thousands of people with diabetes to start using when they talk to and about people. And it's not just about the talking to the people that you work with. It's not your clients. It's not just about that. It's to get people to think differently, to stop thinking of people as, in some ways, as patients, but people that you owe a service to, and it should be a responsible, accountable service to. But it's also about thinking about how you talk about people when they're not there, when they're not in the room, because how we think about people when they're not there, when we then go out and communicate with them, it communicates through our faces and through our body language. If we think of somebody as a nuisance and talk about them as a nuisance in our little private consultations and then go and speak to somebody, that comes across. People know if you don't like them. People know if you have a judgmental attitude towards them. So I think definitely the communication is really, really important. And we did a review in 2017, so just 2.5 years ago, which looked at what communication training was available to haematologists, and it was non-existent. There's guidelines. There are loads of guidelines, but guidelines aren't mandatory. Guidelines are just suggestions, and there's no consistency. So one medical school may do more than another one, and one will do hardly any at all. And as is already said, there's no real pedagogy attached to these trainings. There's no real thought about the education, how you educate people. You have to train people properly in order to do it, and you have to keep monitoring them. Once you've done it, you might do it as a keen medical student, but once you become a consultant, nobody ever checks your communication skills. Medical students get monitored, but nobody ever sits in and says to a consultant, you know, that last conversation you had with somebody was really very poor. That doesn't happen, and that's another thing that needs to happen, is that senior doctors who think they know how to do it, they need to be held to account, as well as training up the junior ones.
Dr. Thomas.
Yeah. And we're going to talk about that later on, I know, about embedding psychological services and an important role psychologists have when they're part of a medical team. You see the doctor, you see the nurse, you see the psychologist. It's normalising psychology, but it's also about having those conversations which challenges those negative views of patients in a closed room. So when you say that, what exactly are you meaning about that individual? So those conversations, we call them cross-fertilization of ideas, because the doctor's conversation, we learn from them and they learn from us. And I think that's a really important way that psychology service, embedding them, is not only a benefit to the patient when they have therapy, but for the wider team as well, in learning how to put those prejudices aside.
I'm going to ask about some of the potential psychosocial consequences of poor communication in a number of different respects. So for taking, first of all, consent, and I'm not asking about the legal requirements for informed consent, but can you just perhaps assist us with the importance in psychosocial terms of informed consent, and conversely, the impact of being treated or tested or entered into research or clinical trials without informed consent? Whoever wants to answer.
Well, informed consent, I mean, obviously, again, it's a sort of pivotal thing within the practice of medicine generally, because any procedure, any test, at least the patient has got to have given tacit consent to, if not written consent to. So if you hear that a healthcare professional has done something to you, that you were unaware of ever having an option, at least, to express whether or not you wanted this done or not, you're going to feel deeply mistrustful of absolutely everything else that follows. And I think certainly my readings of many of the transcripts, when I attended some of the hearings as well, it made my hair stand on end, actually seeing how often people reported that they never even knew that they had been tested for something, so obviously hadn't given any overt consent to it, let alone sort of some of the treatments, particularly when we came to clinical trials, and that's probably another topic you might want to move on to. So I think if somebody does something to you, because that's what was happening, people were doing stuff to patients, and they had no knowledge of having given at least some verbal consent to it, no understanding of why something was being done, or had an opportunity to express whether or not their preferences would be for one treatment or one procedure rather than another, if they had different burdens and consequences associated with them, then that is deeply, deeply troubling for the rest of the relationship that that individual will have, not only with the healthcare professional that they were initially treated by, but everybody else in the system as well.
Dame Theresa.
If I could just add to that, Lesley's described how this can erode, undermine trust. The other thing that consent does is it provides what we could think of as psychological preparation for a test result. So some of the harrowing evidence, people described that they'd undergone testing for HIV. They had no idea that they had, and then suddenly learnt that they were infected. So with appropriate consent comes talking through not only the nature of the test, but the potential results, giving people the opportunity to think through and prepare and have support at the time of testing for the different outcomes. So all of that is lost through not having appropriate consent procedures.
And then you've addressed in the report the consequences potentially and the importance of adequate information and accurate information being provided. If insufficient information is provided about whether it's a test result or a condition or treatment or side effects, is it fair to assume that patients may then have to take on the burden of researching themselves what the condition means? And we heard lots of testimony about that. And they may find information that is alarmist or inaccurate or not relevant to them, and they have no means of knowing what the correct position is as regards their own health.
Absolutely, and I think that leads to even deeper anxiety amongst patients. Dr. Google has a lot to answer for. We're talking about some doctors that you've all actually had indifferent experiences with, but Dr. Google is universally, I think, responsible for causing a great deal of anxiety and confusion. Patients who have not been adequately informed about the consequences of things, the need for different treatments, the side effects, and as I said, different burdens associated with different types of treatment. If they then go online, they fall prey to all manner of purveyors of snake venom and whatever else. And that, I think, in itself just exacerbates the confusion that they're already sort of experiencing. Guiding somebody through the tranche of information that they need to make truly not just informed, I don't like informed consent, I think it's educated consent that allows a patient to pull in their own lifestyle preferences and choices and so forth. That actually takes time, and some online stuff is quite good, but it still needs somebody to direct the patient towards. And I think it was very alarming, again, in many of the transcripts to read how people were just so desperate to try and find out things that they went online. And of course, we are dealing with a time when knowledge in itself about particularly HIV/AIDS was a little scanty.
Dr. Thomas, was there
Well,
something you
just to
wanted
say that in addition to what Professor Fallowfield has said, is really that if you have got poor information or scant information, then how you're not supported to go forward to take on board what are very complex healthcare treatments. And we know that they also have some difficult and unwanted side effects. So if you've got poor information to start with, you're not going to be supported to actually adhere to medicines comfortably.
And I think there's an additional element to this, which is, again, something we saw in the witness reports, is that information was actually withheld on the grounds, apparently at the time, that people didn't want to know. And that was a view very much. I know when I started teaching medical students, there was a strong belief out there that people didn't really want to know the bad stuff. And I can remember seeing a really good paper very early on with the title, "No News is Not Good News. It's an Invitation to Fear." So if you don't get adequately prepared or you don't have that information and you're feeling bad, you fear the worst. All sorts of perceptions and interpretations go on inside people's heads. So again, I think going back, it's still an issue now, but I think back in the old days, information was withheld because people really genuinely believed, I think out of a complete ignorance, that somehow it was not helpful for people to receive information, which is worrying,
Just one small thing, I think also that there's often an idea that communication is like the doctor holds all the knowledge and the patient's a sort of receiver, and the doctor transmits information and the patient receives it, and so therefore communication must have taken place. And I think it was George Bernard Shaw said something about the greatest illusion in life is that communication has taken place. And can we correct it if I've misquoted it slightly? But actually you can't just communicate something like that in one go. You have to come back and say, what did you understand? What do you need me to go over again? And it's an organic, ongoing process with giving anybody bad news, or any news actually, about your medical condition, because you hear the first 2 minutes, and if it's devastating or difficult, you don't hear the rest of the 15-minute consultation. You don't remember anything. You walk out there, and it's all gone apart from the big words that were in capital letters. And then you go in again, and it's almost like, well, I can't ask again because they've told me everything, so I'll go and look for myself. So there's got to be an understanding that communication isn't a one-off, it's an ongoing process of you checking and checking again. And I think that's where nurses serve such an amazingly valuable process, because they're often the ones who pick up the pieces, who sit down and say, what did the doctor tell you? Most of the young people I work with will say, the doctor said blah, 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 because I have no idea what they just said to me. And then somebody will have to go through it again and use different words and visual images, or and different materials and different media. So it's a really interactive process. It's not just, I'm going to say something and you're going to understand it.
And you set out very helpfully in your report good principles or
Yes.
good practice of how to communicate bad news. I'm not going to take time going to that because we've got it in the report. But you've also drawn attention to a particular paper, Banaki, which we've also got, and some elements of best practice when discussing a diagnosis of serious illness. Can I then come on to the question of, as another aspect of communication, candour, openness about when things have gone wrong, where there has been, whether you call it medical error or an adverse incident, whatever terminology you want to use. Now, again, you've set out some principles in your report on page 11 in section 13.4.2. I'm not going to, again, take time to just repeat what you've set out. But I wanted to ask you, if you can, please, to help us with, again, the psychosocial impact upon patients of not being told that something serious has happened to them as a result of the care or treatment that they have been given or not been given. How does that impact upon a patient's experience?
Well, you cited the Elder paper earlier, which actually was exactly about that. It was in primary care, and it was looking at when things had gone wrong from a patient's point of view, from sometimes quite minor things, like being treated badly, to treatments going wrong, adverse drug reactions. There they showed very clearly that, first of all, there were big emotional impacts. People felt angry, they felt resentful, they felt that the thing that really bugged them, and this comes out in the other paper that we've cited there, the Southwick paper, that lack of accountability. That people were not saying what had happened, they weren't even acknowledging that actually it was us, we did this, we had a role in this, or the healthcare system in some way. So there are very clear emotional reactions there, and the Elder paper was relatively minor errors, problems. The Southwick paper, which I think is a really informative one, was about a survey of something like 700 people where there had been serious medical error, and then looking at two things really. First of all, people's emotions, and people's emotions were really, very highly affected. They were things like, surgery that had gone wrong, adverse drug reactions, treatments that have failed, and so on. Again, lack of accountability, a lack of explanation, lack of apology, all those sorts of things really emerged in that. And the effects on people were 90% of people talked about serious emotional consequences and major financial impacts as a result of all of that happening. And so the impacts there were huge, absolutely huge. It was in the US where the financial aspects of health are, fortunately, from our point of view, a little bit different to they are here. But even so, the impacts were huge. That review or that survey, I think, is a very powerful one, very powerful indictment.
Can I add something to
Yes.
that? I think that moving on from what John's saying is that also that was the emotional impact, but the paper actually goes on as well to discuss the behavioural impact. And the behavioural impact where somebody feels that the acknowledgement of error at whatever level has not been made, that people stop going to the doctor and they do things like go, not then, but on Google. You do search for your answers elsewhere and you avoid going back to that doctor, and often you avoid going back to the whole system. So the healthcare system becomes something very negative in one's life, whether that be the nurses, the hospital itself, whatever. And so your healthcare is therefore going to be compromised because you're no longer going to get the care and the help that you need and you deserve because of your behavioural anger towards that doctor, nurse, whoever.
Just to add that the justifiable anger, which the paper actually speaks about quite well, it comes through very clearly from the transcripts. And if you are stuck with that anger, you sort of can't move on with some aspects of your life, really, because nobody's acknowledged and sort of taken responsibility for what's happened to you. So I think that just goes on top of all the other psychological distress and psychosocial concerns that our population have gone through.
Dame Lesley.
I was actually going to say something rather similar. I mean, when I did quite a bit of work with what was then called the National Patient Safety Agency, when we were trying to encourage more open disclosure. In fact, the programme ended up being called, at the time, Being Open. We were very struck when we spoke to patients who had been the victims of sometimes some very serious medical errors, including sort of infected blood, but there were many other sorts of things, operations that had gone wrong, wrong drugs being administered and so forth. We were very struck with how those who were stuck with the anger, they were so incensed that people had never just fessed up and said right at the outset, this was our error. We apologise wholeheartedly. We are going to investigate exactly what went wrong here. In the meantime, we're going to do everything possible to try and help you. And furthermore, and this becomes the important thing for many of the people that we spoke to, they wanted to know that something would be done to stop it happening to others. And it was the failure, I think, for people to, first of all, acknowledge the problem, but then not actually try and put in place measures that would ensure it would never happen to another person. And look at the hundreds of you who I'm quite sure actually also experienced exactly the same feelings. Anger not just for what had happened to you, but anger that it continued to go on. And that's one of the reasons that the National Patient Safety Agency actually sort of changed their name to the National Reporting and Learning System, because at the very least, apart from personal acknowledgement and recompense for what had happened, people so wanted the system to learn so it wouldn't keep on happening to others.
Just in relation to that guidance being open, which was 2009 guidance, I should say it's guidance that relates now to England, but there is guidance in Wales, Scotland and Northern Ireland, and we will obtain those and provide them to call participants. You talked also about the Australian study and about the legal duties of candour, and again, we'll provide information to call participants about the duties as they apply in different parts of the United Kingdom. But I understand that duty of candour worldwide is not necessarily a new thing, and that there's at least one country that recognised it in legal form decades ago. Could you tell us about that, Dame Lesley?
Absolutely. I mean, in New Zealand 40 years ago, there was a duty of candour that at the moment an error was spotted, there was a legal responsibility, a mandatory responsibility to report it and set in process not only treatment for the individuals affected, but also the legal means to get some recompense for this. And I think Australia and New Zealand actually were probably ahead of us, but New Zealand, it was 40 years ago they first published their work on a duty of candour to investigate, learn and recompense the people that had actually been affected in whatever way it was.
And Dame Theresa, was there something that you were going to add?
I was just going to mention that really in this context, and some of the witness statements emphasised this, that insult was added to injury, where sometimes people were encouraged in a hostile way to take blood products and were falsely reassured that they would not be infected. So not only was there, if you like, an error in terms of an adverse medical outcome, but they were falsely reassured that what they were being given was completely safe and they should not be making such a fuss. So I don't doubt that that would further contribute to the psychological toll on those individuals.
And then can I just ask you a little about apologies, what they mean, who they might need to come from, how they might need to be expressed. First of all, an acceptance of responsibility or some kind of comprehensive apology, if made promptly, is presumably likely to be of greater benefit than if it's made begrudgingly or many years after the event.
Absolutely. There's so much evidence that really what people require is an immediate hands up, something went wrong here, rather than, well, what's going on here? I don't think this is right. Why isn't anybody actually talking this through with me? There are several things about apologies, though, that are quite interesting to look at. First of all, a formulaic, the hospital are all extremely sorry that this has happened to you in a letter. That does not work. That really doesn't cut it. The apology has to be personal. It has to be face-to-face. It's not necessarily the doctor, nurse, that was responsible for administering the drug or cutting the arm or leg off or whatever it was, who has to be there. It should be, though, somebody who is experienced in some way. They have as many facts as are available in front of them, but that they can personalise the apology. Because too many people report that it's just a pat sort of, cut and paste letter. And that is not an apology. And even with the apology, we are so sorry that this has happened to you. There has to be a look. We still don't know all the facts because you can't always identify exactly what went on, but we will put in place now an investigation. We will keep you appraised of how that goes as more facts emerge. But first of all, I want to know how you at the moment are actually feeling, what we can do, how we can best support you. And by the way, this is the treatment that you're now going to actually really need. Now, that sounds a lot to do, but it can be handled well. And one of the things that, again, the National Patient Safety Agency, being open programme, started, it wasn't just that we wrote a big report, we actually did develop some training modules that were meant to be used by all hospitals, where individuals would take responsibility for, sort of dealing with medical error of different sorts of severity. They'd come to the training programs, we trained them, and part of that, the most important part of it, was how to do the apology. The other thing is that when you're dealing with a family, of course, they're likely to want very different types of apology. And so that's what I meant by the personalising it, rather than just a formulaic, I'm sorry this happened to you, it won't happen again.
Your report and your evidence obviously focuses upon apologies, candour within the healthcare setting for obvious reasons. But would the basic principles that you describe of the importance of there being acceptances of responsibility, candour about mistakes, potentially also apply to government, to other public bodies and institutions and politicians and individuals?
You're getting into very sort of touchy sort of ground here, because obviously there are levels at which the buck should stop, and sometimes the people that actually really have to be made the sacrificial lambs are not really the people who were responsible. And I guess with certain sorts of, I use this term, well, I don't think you can describe it as anything other than scandals. One of the problems with scandals such as this is that there were probably people who knew a long time ahead, for a long time, what was happening, and yet for whatever reason this was concealed. And I think that there does need to be a very public apology at the highest level, but meant sincerely.
Just one further aspect of candour and communication, but a slightly different one. Significant numbers of witnesses to the inquiry have reported either lost or missing medical records, incomplete records, destroyed records, or they've reported difficulties in accessing records, either their own records or the records of deceased relatives. Some might view it as deliberate. That may be their view. Some may see it as evidence that they are unimportant, that what's happened to them doesn't matter to the organisations that they're asking for this information from. How might that, again, impact upon the psychosocial experiences of the individuals?
I think that's likely to have a serious sort of impact on them in terms of trust and confidence in even something such as this inquiry, sadly. You know, if things go missing and it was the people, you know, who call all the shots, people in power who actually allowed this to happen. I mean, it's funny how similar sorts of documentation appear to have all gone missing at the same time in wildly different hospital situations, schools and whatever, isn't it? But if people feel there has been an institutional concealment or cover-up of things, it's going to make them really, really difficult for them to trust even, I guess, what we're saying.
I'm going to move on to my penultimate topic is difficulties in accessing treatment, which I can take shortly, and then there's a slightly longer topic in relation to care and support, which is an important one and will need some time. So, if I may, I'll just trespass into the break for 2 or 3 minutes to deal with the penultimate topic. The question of difficulties in accessing treatments, for example, drug treatments for hepatitis C, is a theme of many statements. Now, I'm not going to ask you to comment upon what the reasons for that might have been. We know there are issues about rationalisation, funding, and the like. There may be all sorts of other impediments to giving people treatment. I wanted to ask you about what, the psychosocial consequences for individuals, particularly individuals who have been infected as a result of NHS treatment, then being denied the treatment or having that treatment deferred that might address the consequences of that. How might that affect them?
You'd feel victimised, wouldn't you? Doubly victimised, I think.
I think that the whole issue of access to treatment is quite a complicated one, because there are lots of reasons,
Yes.
or lots of different sorts of access problems, as you've alluded to. And some involve, just the fact that the centre was somewhere away, people had distances to travel, when they were feeling fatigued, nauseous, whatever. And so I think some of those impacts were horrendous in just the toil, that took, the toll rather that took on people. I think where you're looking at sort of other, what I would call more pernicious aspects of access difficulty, I think where the problems really compound. So where people talked about feeling that they were not prioritised, feeling that that they were being discriminated against, maybe there was rationing, they weren't, or even when there are sort of perhaps cost-related issues, that there I think what that really added to was sort of a little bit like what Lesley was saying, a real sense of discrimination and stigma. You are part of a group who actually somehow were not worthy of the sort of healthcare that you should be getting. And I think there were two very different, the access issues which the individual experiences, and then the ones which are the more practical ones. And I think that second group, that more pernicious group, where people felt that they were not getting the sort of, they were being blocked off in various ways from the sort of treatment they should be getting, could be getting. I think the impacts there are huge, the negative mood, distrust, dissatisfaction, a large amount of work looking at patient satisfaction with healthcare, huge dissatisfaction there, lack of confidence in the whole healthcare system, reluctance to follow advice and treatment. I think, all sorts of behavioural psychological impacts of being blocked off in that way, of finding it difficult to access. And again, it's consistent with literature. There's a big literature on HIV, again, which is very parallel to that, just HIV on its own, not in the context of, infected blood.
Thank you. So the final topic, which I'll deal with after the break, is about psychosocial care and support, and also picking up on some issues in relation to VCJD notification. I would ask any call participants through their recognised legal representatives or otherwise, if they have additional questions arising out of what they've heard so far that they would like to have put, to raise those with their recognised legal representatives, who will raise them with Ms Lee and Ms Scott during the course of the break, and to the extent that time permits, we may be able to ask some additional questions.
I would ask them in that case to make sure that you know in good time in order to work out what you're going to ask in what remains of today's hearing time.
Yes, ultimately it means the lawyers sitting behind me will have to miss their break, but so will we.
Well, everyone else won't. And if you can be back, please, by 3:30. So just a slightly shorter break, 25 minutes.
Right.
Yes.
So I want to ask you now about the question of psychological and social care and support. Starting with psychological support and counselling, first of all, do you consider that the provision of counselling and psychological support would have been of benefit to patients infected with hepatitis and HIV in the way that we've heard?
Yes, absolutely, without question, without question. There's very good evidence that when somebody receives a diagnosis that is challenging and distressing, that proper, adequate psychological counselling and support can make a significant difference to their ability to develop coping strategies, to the family's ability to manage. So there's absolutely no question.
And family support, informal support networks through groups such as a number of the groups that we've heard described are clearly very, very important, but they are important in their own right rather than as a substitute for psychological and professional assistance.
Yes, I mean, there's a difference between a support group which is there to activate political support in some ways, to have the condition recognised. What I would say is that what's needed is a number of different therapeutic kind of support groups. So there are therapeutic groups where those are facilitated and supported using psychological theory and psychological therapy techniques to help people share. It's really important not to re-traumatise people. It's really important. We know that just getting people to tell their story again and again and again and again just creates a re-traumatising situation and is not helpful. There's got to be a way of people working that through, of transforming a distressing emotion, recognising their own resilience. There are lots of different ways that people can be supported, and people can and deserve to choose the kind of therapeutic support that works for them and when it's the right time for them. So at the immediate point of diagnosis, it can be too raw, too painful, too difficult to sit down and talk with a psychologist. But there will be a point at which they should continually be asked, how are you doing right now? How are you dealing with it right now? What kind, who would you like to talk things through and work out what would work for you? And that might be individual work, or it might be family work, it might be couples work. There are a vast range of psychological approaches and psychological therapies that will fit different people in different ways and have good outcomes.
And in the absence of formal psychological support, is there a risk that patients may develop their own coping and adjustment strategies? And that might include strategies that are damaging or harmful. We've had some accounts, for example, of people turning to alcohol and to drugs as a means of coping in the absence of any other form of support.
That's absolutely right. They can utilise unhelpful coping strategies which undermine their own physiological health systems and mental health systems. But I think it's really important that for us as a group of psychosocial experts, what's come out again is that individuals have found important ways of transforming that experience and making that experience a positive one. And so resilience has been a really important thing that's come out, that they have found ways, individual ways of, without support, of becoming resilient. That's not to say support isn't important, but we must acknowledge that they've found ways of doing that. Just to add to what my colleague was saying here about, there's quite a lot of research that shows that with adding psychological care in the context of a medical setting, that you can reduce psychological distress, you can improve the coping mechanism, and the frequency at which people are hospitalised and how long they stay in hospital are enormously benefited from adding psychology to the team. I think it's absolutely right about what you're saying about what kind of psychology services are available. And in my experience, and certainly when I was doing the work trying to do the literature search around this, we found very little evidence for hepatitis C patients who had been infected or haemophilia patients. And the large support literature has come from the HIV literature, which, people were infected, MSM literature, which in some ways, although they had support structures there, people with haemophilia didn't necessarily feel that they could access those.
Yes.
And I think that was also an added problem. And I don't know whether you want to say something about that, Sian, because you've got more direct experience of that.
I mean, it's interesting because we cannot pretend that in this era that HIV psychological support was absent. In many areas, there was enormous support. There was fabulous communication of the things that we have talked about and that witnesses have expressed. In some areas, in the HIV specialist areas, there was a lot of resources. There was a lot of money being put into this area. When we think about healthcare services, we think about when you want a good healthcare system to work for you, you need somebody who has in-depth knowledge, who has expertise, and who has experience. And in the early days of the 80s, nobody had any of that. And so what happened in many of the HIV specialist centres, where people were coming into the service because they wanted to be there as healthcare professionals, the question was, tell me as a patient how you want to be nursed and how you want me to care for you. And actually that was very transformative in the HIV specialist services. And in that area, there was huge psychological support. On our discussion earlier on about communication, on one level it's about patient and doctor, and another level it's between healthcare professionals. And I think in some ways we didn't access some of the support that was around for all sorts of reasons, because much of the support was seen as HIV specialist care, that was seen as something that was focused on gay men who were infected with HIV and therefore inappropriate or not targeted, not sympathetic. The Birch Grove report that we mentioned earlier on talks about this a lot. And in retrospect, did we do something wrong? Did the healthcare workers? We talked about prejudice within healthcare workers areas. There were many doctors who would not refer to specialist areas of HIV, and I think we can't pretend it wasn't there. I think what we do know that it wasn't accessed, and often referrals weren't appropriately made, and it may be that it was not appropriate.
Is there still the potential for benefit for patients to access psychological support services now, so many years after some of the initial events?
Absolutely. Absolutely. I mean, it's in the break I was speaking to HIV, hepatitis C sufferer, and who was talking to me about how she had managed to hold on to a lot of her information and the secret around carrying hepatitis C, managing herself and also her daughter and her family, and how this has been, on the one hand, she sees herself as being quite strong and has brought out her resilience, but actually it's that's sort of loneliness of carrying that has actually meant that she hasn't had a space where she's given permission to kind of debrief and look at, all of this, the distress that she's had. So I think it's immensely important going forward.
I mean, every single transcript that I read, and I can't remember how many I went through, but I went through a lot of the transcripts, and every single one that I read, I could see the potential for support and help from psychological therapy in every single transcript. For some people, that I felt that there was the opportunity to work with an individual to help them with some of the guilt that they'd experienced. There was opportunities for families to support the family and help the family see what an amazing job they had done. There was the opportunity for parents to help them think about how they'd managed to parent despite the difficulties that they'd had. For young people to realise that despite having lived with this really awful, challenging condition throughout their teenage years, how they had turned into amazing individuals. And therapy can be about good stuff too. Therapy doesn't have to be, you don't have to be sad, bad or mad to see a psychologist. You can just be living with stuff that you'd like to work through. And the service that I work in, we see people to celebrate. We see people to celebrate and witness their triumphs, not just to talk about the miserable stuff. And there's some very good work in the narrative field, which is around people who have lived, a lot of it actually interestingly coming from New Zealand, where people who've lived with trauma and who've lived with abuse, which is what a lot of people effectively have experienced. They've experienced abuse, iatrogenic abuse by the medical system, for them to actually come together to witness and to celebrate the fact that they have survived and that they are survivors and should be really proud of being a survivor.
Dame Lesley.
I think actually Professor Christie's just made some very good points there, but one of the things I guess I'm sort of mulling over is, just as there isn't a generic form of support that would be appropriate for everybody, it's got to again be very individualised and personalised, and sometimes it might be groups, sometimes it might be just one person. But I feel, from all the things that I've read and the sort of spontaneous conversations I've had with some of the affected and infected, that until particularly this inquiry comes to some conclusions, the reconciliation process that will bring a great deal of comfort and support to people can't be achieved. You know, you can talk and talk and talk about how you feel. You can talk about methods to, you know, manage your anger, your resentment, your feelings of guilt. You can do all that, but I think the greatest form of support for a large number of people is going to be achieved by a successful outcome from this inquiry and reconciliation.
I feel like I'm at the
And one issue that has, or one concern that's been expressed by a number of people is about the variability amongst different parts of the United Kingdom and the different schemes within the United Kingdom, different elements of both psychological and social support being available. And that's engendered in some further sense of discrimination or stigmatisation. Is it fair that they understand it in that way or experience it in that way?
It's absolutely accurate. There is a postcode lottery for mental health care across the whole of the UK, and depending on where you live will determine whether or not you have quick or indeed any access to a child and adolescent mental health service or an adult mental health service, whether or not you have access to increased psychological therapy access via your GP. Some GPs will pay for a counsellor, others won't. It's appalling that there is a really significant postcode lottery in relation to support for emotional well-being.
And a common theme. I'm sorry, Dr. Thomas. Yes.
I just and where there are psychologists and within haemophilia or hepatitis C services, the access is very, very variable as well. So you may have, say, I can speak for my centre, psychologists providing 3 or 4 days to haemophilia centre, and then you go to Ireland or Scotland and find that you've got one psychologist doing half a day. So how does it possibly meet the need? And I think it's disingenuous sometimes on healthcare providers to say they've got access when the calibre of the access or the quantity that they've got is extremely limited, and it's those things I think that need challenging.
One of the common concerns expressed by witnesses has been where they've attempted some form of psychological support, accessing some form of psychological support. It's been at a level of general mental health services, and they have found themselves having to explain the history of infection through blood and blood products. And so a number of witnesses have said what they would want is a service which is sufficiently specialist and focused that those who are delivering the service understand and have a good knowledge of the history as well as of the particular conditions of HIV and hepatitis C and its consequences. Would you agree with that?
Absolutely, and again, I draw on my experience, and certainly some of my patients are in the audience here, where we provide what we call a dedicated service for people with haemophilia. So you have an expert knowledge of haemophilia as well as hepatitis C and HIV, and there are joint clinics that are run within the haemophilia centre with all these professionals who come to the department, and that involves a psychologist as well. So I do think if the psychologists need to have that history of infected blood disorder as well, infected blood products, and so that the individual feel that they can go and they're in safe pair of hands. They don't have to start explaining themselves all over again, which is very, very distressing and wearing, takes its toll. So I do think embedding psychology service within a medical team, so the doctor, the nurse, the psychologist is there, normalises psychology, so there isn't a sense of, you see the psychologist and you can have informal conversations, and when individuals are ready to have that referral or see psychologists for a one-to-one and detailed psychological support, they've already sort of bridge some of those initial conversations, and then it doesn't feel like it's something that's foreign and unusual. I think the other thing to say about that is, and just we have spent a lot of time demystifying what psychology is. You bring to us, you are the experts with your health problem, and we are learning from you as psychologists. We are novices. And so there may initially feel like there are power dynamics in the room where we, the psychologists, are powerful. But the important role is to educate the individual patient to say, actually, you know more about this than I do. What is it you want from this therapy? It's not what I'm going to tell you you need, it's about what you feel you want to get. And that's a really important way I think services should be structured.
You've referred in the report to UK quality standards for haemophilia and for haemoglobin disorders. Now, obviously, at the risk of perhaps stating the obvious, that's only going to be available for individuals who are accessing those centres because they have either a bleeding disorder or a haemoglobin disorder. So that's not a service that's open to those, for example, infected through transfusion. You've also, I think, alluded to the fact that there's very different availability in different centres across the country in relation to that. For some, and some witnesses, not all have said this, for some, receiving psychological support at the centre where they were infected, albeit involving treatment from different individuals a number of years before, is itself problematic.
Yes, yes. And an important dimension in terms of how haemophilia, I can only speak for haemophilia, obviously, and it is absolutely right that other people who are infected also need support, and that sort of specialist focused work in an area that is non-stigmatizing is very important. That, in a way, it's important that going forward we are actually taking account of what people are bringing to sessions. And I've lost my thread of what the question is now. Can you repeat that last question?
I'm going to have to check. No, I can't even see it on the transcript. I was asking, I think, about the people having to go back to the same centre where they had been infected.
Yeah. So haemophilia centres have actually then provided kind of outreach work, and certainly one recommendation would be, and within our centre, we would go out to centres to actually see patients there. And of course, this is not always possible because it comes back to resources again. If you don't have adequate psychology resources, you can't provide that. But that would be an ideal way of meeting people within their community or linking them up with appropriate people in their community to get that support.
Dame Lesley.
I wonder if I could slightly disagree in the sense that for many people, what has happened is they've lost trust. And if you're going to re-establish trust, you can't actually do that by sending them somewhere else. And also some people live in, certainly parts of the devolved nations, Scotland, you're miles and miles away from specialist centres. You're likely to actually experience other sorts of illnesses and ailments, or your family will, where you'll have to be treated in your local centre. And so I guess I'm sort of thinking about a little more widely as we're talking about this, that perhaps also there's some support services that are required for the healthcare professionals who inadvertently have been actually involved in these errors. It's not been their fault, not their responsibility. It might have happened years before they ever even joined the service. And unless we, again, I'm coming back to this reconciliation, it works both ways. There are some probably quite damaged healthcare professionals out there who feel desperate about the situation of the families and also have a sort of corporate guilt themselves that their institution or hospital did this to people. wittingly or unwittingly. And I think unless we can try and re-establish the trust factor, it doesn't matter sending somebody a million miles away. They might still feel mistrustful of healthcare professionals there.
Professor Christie.
I suppose I wanted to kind of suggest something slightly in the middle, because I think I agree with absolutely with both positions. As a psychologist, you don't have to have diabetes in order to work with a young person with diabetes. You don't have to have a particular condition. You don't also, but what you have to have is an understanding of the impact of illness. Now, I think one of the things that's really striking for me was when I started to read, to start to get a sense of understanding how many other people there are out there who have developed these infections as a result of something other than having haemophilia. And so the people that you're referring to who aren't going to a haemophilia centre because they became infected through a pregnancy transfusion or an accident or something like that. So I think it is possible to think more widely. I think it's possible to have a trained workforce, and I think you would need to think about how people are trained in order to start to help people think about these really unusual. This is not usual. You don't come across people who've been infected by a healthcare service in your everyday work. But it is possible for psychologists to work if they have an overall all understanding. And I think and Lesley has also said this, that actually it's not going to be possible to have the infected psychology service. It's just not going to work, because everybody here in this room is different, and everybody here in this room will have a different thing that they need to think about or work through. So again, the workforce has got to be of an adequate calibre, and Nicky used that word calibre, it's so important. It's got to be people who can work with difference, with diversity, with uncertainty, and not quite know where they're going to go, but be able to be driven by what the person coming to them is needed. So I'm not entirely sure that it does need to just be in haemophilia centres. I do think there needs to be some embedding within a medical service. I think psychology for chronic illness and emotional distress is very different to just mental health. That's why we don't have good evidence for what kind of treatments are needed. We know what works for people who just have depression, but we don't know what works for people who have diabetes and depression or HIV and depression. We don't have the clinical trials to tell us, but we have the clinical skills to know what might work. We need to be flexible, and we need to be adequately resourced, because without adequate resourcing, what we will get is an unqualified workforce that will provide unhelpful, low-quality services, and people will say, well, we're doing something, and that's not good enough.
Dame Theresa, is there something you wanted to add?
Yes, and just to say, it's not my area of expertise, so I defer to what I'm hearing here. But I'd just like to add that I would want to think about this not just in terms of psychologists. There are other healthcare professionals who can provide expert counselling. And I think we also need to look at this in the context of the lack of parity between mental and physical health. And Sir Simon Wesley, who produced a report for the government before last, I think it was under the Prime Minister Theresa May, who wanted to see a levelling up, if you like, of resource for mental health services. So I would see this as part of that, as well as having the particular colour that it has here. And we've talked about medical errors, and I don't know what provision there is within the NHS for managing that. So there are going to be very, very expert services, such as the kind that Nicky is providing, but I would want to see a response that goes across the piece for all the reasons that we've discussed.
And would you also expect psychological care and support to be available to affected individuals, in the sense that the inquiry has used that term, family members, partners, children, etc.
We opened this morning by stating very, very clearly that nobody lives on their own with this. That the illness, the condition, the infection is in the family. One person may carry it, sometimes more than one person may carry it, but everyone in that family lives with it. And you cannot provide good psychological care by just focusing on that one person. You have to think about their wider system. You have to think about whether their siblings, friends, aunties, uncles. You have to think about everybody, parents, grandparents. Everybody needs to be considered and included, because one person may be infected, but everybody is affected.
Just to add, infected, affected, and a very important point not to lose sight of that Lesley's already mentioned, the healthcare providers. I think it's absolutely key that any kind of training that we talk about continues through in terms of providing support for those individuals to be able to manage the situations that they've found themselves in.
A number of those who've given evidence about bereavement have pointed to an absence of psychological support for them, either in the weeks or months preceding death or in the weeks, months and years after death. Would that be another important part of any service offered?
Yes, and actually some of those things exist. I mean, certainly when I worked at the London hospital, we had a bereavement service that was actually run not by specialist psychologists. Myself and a psychiatrist called Colin Murray Parks used to train up very good counsellors, because we just didn't have funding or enough personnel to offer the service. But they were very good at actually visiting people, compassionate friends. There are quite a few bereavement services that I think with a little extra support and training, you could realistically help to do this job.
And can I ask if an individual is reluctant to access psychological support, and there may be all sorts of reasons, many of which you've discussed why that might be the case, how active should healthcare professionals be in trying to encourage that individual to access support services?
So I think everybody has to get to that place where they feel ready and able to take that kind of support. But if you don't know that that support exists within your vicinity of where you're getting the care, then that's just such a travesty, that we healthcare professionals are not doing our duty to our population of patients. So educating our patients about what the service entails is a really, really important thing to do, and what it means. So normalising it again. I remember when I started working in Psychosocial all those years ago, this psychology was seen as such a stigmatizing area. And one of the biggest advocates for it and enabled patients to access it were the clinical nurse specialists. They would talk about it in a way that was useful and helpful, that the patients could access about all kinds of things that they would find it useful for. But so there's a role for the healthcare professional to sell it, if you like, in a way so that they know it's there. It's part of the service that they can access. But if you don't know it's there, you won't. It's another barrier, and you struggle for years, and then you suddenly discover, oh yes, it's there. And I think so. That's an important role.
You should just never stop asking, because you just never know when people are going to be ready. So some people will want support immediately when something traumatic happens. Other people will be ready in 6 months, other people 6 years, and some people maybe 20 years. So, there'll be young people I'll see who will categorically refuse to see me, and will I know, can you believe that? And they will say, I can't see the point of this, there's no point in talking, and we'll say, that's fine, let's try this again in 6 months' time. And we start at 12, and when they're 18, just before they're about to be transferred to adult services, they go, I've changed my mind, I'd like some psychology now. But there are equally people who get in touch with me 6-7 years later after I saw them in their early 20s and say, I just wanted you to know I finally did what you suggested and I went and saw a psychologist. I wish I'd done it earlier. So it's never, ever, ever, ever too late. If you feel that there's something that's not quite right, if you feel that you need help and support, then go and ask and keep asking, because you will get it eventually, but you just have to persevere,
And if we just broaden out the discussion from psychological support to other forms of support more broadly, social support, what other kinds of support might alleviate some of the psychosocial impacts that you've identified?
Decent financial support.
Yes, definitely.
Decent financial support, so people aren't. We heard this morning and early this afternoon about the massive impact socioeconomic financial hardship has on people, on their physical well-being and on their mental well-being. So appropriate and adequate financial support can make such a difference to people. It can help a family go on holiday, something as simple as that, but that could make such a difference to people's well-being.
Yeah.
So I think financial support, very, very important. And social support is a major mediator of physical well-being. So creating good social support systems, and again asking people, it is absolutely essential for healthcare professionals to keep asking the people that they're working with, how are you doing? How are you doing? What can I do to help you? Not tell me what your blood levels are. That's not the question. What can I do to help you today? What is it that will make your life better? That's the question that needs to be asked. And when somebody tells you, it's your job then to do it. And often it's not psychology. We get families that we see where actually what they need is a decent house to live in, decent accommodation, a decent school. They don't need a psychologist to fix. They're not depressed. They're living in squalor, and psychologists can't fix that. So good social care, decent social care.
There is one other thing, of course, that we're sort of slightly forgetting, and that is that not everybody lives in a warm family environment. There are lots of people who anyway contracted all these awful sort of diseases who were already socially quite isolated anyway. And I have a slight concern that the only people who usually knock on doors asking for help are those who are already actually in receipt of some of it. And I think it would be quite useful to be a bit more proactive in seeking out those who had lost loved ones when they were already socially quite isolated and who don't have any existing supports. If we have to focus our efforts on individuals because of a lack of different sorts of resources, manpower, money and everything else, I think there's a very needy group who don't have a voice at all. They don't have a friend, they don't have a family who'll shout and beat the drum for them.
Dame Theresa, can I ask you now on a slightly different topic about the consequences of VCJD notification? Your report very properly draws attention to what I think is the only study that has looked at the psychological or emotional consequences of being told about the possibility of exposure to VCJD. And that study, which was a small one of 11 individuals, found in those 11 individuals no evidence of particular long-term emotional psychological disturbance. As the panel know, the evidence that the inquiry has received from in excess now of 2,000 statements paints a different picture. Not everybody obviously responds in a different way. Each people respond in their own way. But we know from what we've been told that it's something that has weighed very heavily on a number of individuals and has been a cause of considerable fear, anxiety, psychological distress. And Dame Theresa, I think you have some observations about why the study which you spoke about wouldn't be representative of the broader group with whom we're concerned.
That's absolutely right, and thank you for giving me the opportunity to expand on that. So the only study that has been conducted looking at people who have been notified that they have a risk of about 1% of having become infected with variant CJD. So there's a very low risk. The only resource that was available was to interview 11 people, and those individuals, as far as I know, had not already had experience of being infected through healthcare. So these were individuals who were being informed of a real but theoretically, a low risk for a condition for which there was no test and no treatment. And what we know from those individuals, so they're self-selecting, so they were approached, but if you were feeling pretty ropey about that notification, you would be unlikely to come forward to be interviewed. And we know from other research that those who respond to life-changing risk information, how they respond is very much predicted by their psychological and emotional resources before being notified. So the main study in this area, which we cite in the report, was a study which might feel very removed from your experiences of those who are found to be at risk of an inherited condition of Huntington's disease and undergoing testing. And the thought always was that if you were found to have inherited the gene and you would go on to develop this condition for which there was no treatment, you would be understandably depressed and anxious. And if you found you hadn't inherited the gene, you would be not anxious and depressed. Whereas what the evidence told us was that how you felt before the testing predicted how you felt afterwards. So if you were depressed and anxious before, regardless of your test results, you felt like that afterwards. So that's a long way of saying that initial vulnerability is extremely important in affecting how people respond to being given risk information about their health. So for those who had already been informed that they were infected through treatment that they've been receiving, whether it's HIV or Hep C, to then learn that they had a chance that they have been exposed to another infection, that would lead me to predict, on the basis of what we know, the impact would be very, very different.
And then going back to questions of communication, how does what you told us earlier about good communication inform what should be the right approach to this situation, where you're not telling somebody that they have been diagnosed with a condition, you're telling them that they may have been exposed to something that cannot be tested? Are there any recommendations or observations that any of you have about how that should be approached?
I think, again, it would depend on the individual. So for those, such as the infected and the affected, that are the focus of this inquiry. So already within a healthcare system where people are dealing with the damaging consequences of having already received blood or products or undergone surgery where they've been exposed to infection, I think, as Lesley's already outlined, face-to-face communication, explaining, and as Deborah's already stated, it's not sort of one way. So there's an interaction with an individual, with a healthcare professional who has all the information at their hands, being able to explain in a way that is effective and that and sensitive. So checking that people have understood what this information means, and providing them with the support that they need to adjust to get more information about a potential infection.
Dame Lesley.
I'm always very interested in individual differences and how different people respond in ways that you think, this is really strange. Why is one person devastated by the news? Why is another entirely, sort of cool about it? And there's a very interesting test you can give people, quite a quick one, called the Intolerance of Uncertainty test. And it's quite robust. And it really is highly predictive as to how well people are going to cope with different sorts of risky information that involves uncertainty. So if you have a high intolerance to uncertainty, you are likely to find it very, very difficult to live with that, and will need a lot of really quite intensive support services to help you through it. But if you're somebody who actually has a high tolerance to uncertainty, then living with this information is probably not in the order of things as difficult as, thinking about whether or not your football team will win on Saturday
But critically, it will, to add to that, depend on your pre-existing, how you are feeling, what your emotional resources are. So added on to that.
Added to it, yes.
So not everybody, but many of those, as we've read from the accounts of the witnesses in this inquiry, these were individuals who had already had to deal with errors that were being made. So to add to that with something else that, for those who hadn't previously had that experience, actually in the ordinary course of events they could deal with it. But actually it's like the final straw for many people.
There is also, when you're looking at people communicating about risk and uncertainty to patients, something that's quite interesting. The same words can be received very differently by patients because of the nuance, the way that people actually express themselves. And I think that's another reason why we feel quite often in certain situations about when an error has occurred, when an adverse event has occurred, you should actually have somebody talking through the implications of this with a patient who has actually had some specific training and will recognise when they are offering that information in a way that actually biases, if you like, things to over-optimism or over-pessimism. Being objective about the information you're giving it can sometimes sound quite cold, but you really don't need somebody to either over or under egg it. And again, healthcare professionals have different tolerances to uncertainty and risk as well.
Could I also add that having sat on one of the many panels that were set up by government to deal with variant CJD and the implications of it, it was very much informed by what was considered to be, and I would have to choose my words advisedly, so not a scandal, but a recognition that what has happened to many people in this room should not be repeated. So you could tell by the communications that were happening with people who were at risk for variant CJD, there was going to be no sitting on hands. People were going to be given the information, and a lot of care went into the communication of that. So little comfort, I suspect, to many in this room, but already there was some learning that was happening as a result of the experiences of you in this room.
And we've heard from one witness whose son died in consequence of VCJD. his son's experience of the care and support that was available, and your report alludes to the specialist provision that was made for people diagnosed with a prion disease. But his experience was very different from the experience that the majority of infected individuals and their families have described of their own experiences of the trusts and schemes set up to support them. And I think you've drawn attention in your report to that specialist service, the specialist guidelines for social workers dealing with VCJD, and a national service that has been established. I've one further question, and then a handful of questions that others have asked to be put to you. You will have heard from what you've read, and those of you who heard the intermediate was evidence yesterday from intermediates, that there are a number of individuals who, in giving their witness statements, giving their oral testimony if they've done that, or speaking to intermediates, are speaking for the very first time about deeply personal and deeply traumatic experiences. Some have reported that has, in some respects, felt cathartic. But is it fair to say that for some, that very experience may also be traumatic? And if so, what kind of care or support should potentially be being made available for people who are reliving distressing events?
I mean, I would say that the research does say that asking victims of trauma to recount their experience creates a re-traumatizing situation, and one way you could re-experience the distress that you went through the first time. So just as the question that you asked about what should we do, we should offer what we can. So we need to make sure that anybody who has been brave enough to stand up and tell their story needs to know that help and support is available, and it should be offered. It may not be taken up, but that's somebody's preference. But it should be offered.
I've again, as I say, a handful of questions from various call participants and their legal representatives. One is a question for clarification of something Dame Lesley said when we were talking about consent earlier, and you used a phrase tacit consent. And I wondered if you could explain what you meant by that phrase.
Well, we have written consent, for example, if you're going to go into a clinical trial or you're about to have a knee replacement or an operation. But for certain sorts of treatments or procedures, the doctor will just say, I think we should run a few blood tests, and the patient nods. And that's taken as tacit consent, which I think has been potentially a big issue here in this particular problem that patients have had. A lot of the people who actually claim, and I don't doubt them for a second, that tests were done without their knowledge, I bet you'd find most of the healthcare professionals would argue that you had provided at some stage some tacit consent. I can see somebody shaking their head, and that's exactly it. They would have picked up or thought that they had actually got your approval. Some of them would have done. And that's what I mean by tacit consent. If somebody doesn't actually put their hand up and say, excuse me, but what exactly are you doing here? What does this involve? And they just nod. They've given tacit consent sometimes, some healthcare professionals would say. I don't agree with the practice, but that's what I meant by it.
And that reinforces the importance perhaps of two things. One is the provision of full information by the healthcare clinician as to what they are doing or what they are asking the patient to agree to. And the second is the importance of written consent, of recording that.
Yes, absolutely. Yeah. And checking that people have understood what they've just signed, because that's another thing. Many consent forms are actually written demanding a health literacy skill that most of the population don't have. The health literacy in the UK is probably about that of 25% of the population have health literacy skills of a 10-year-old. And if you look at most informed consent forms that people sign, they are way beyond that. They're graduate level reading skills required. So I don't think it's just that we need written consent from people. Somebody should go through the form with them and say, have you got any further questions? What does this mean to you? Those sorts of open questions.
And then a next question is about care plans for treatment. What are the benefits, the psychological benefits of having an agreed care plan and of having input into that care plan as an individual?
So, an important benefit from that is that the care plan is individualised to that patient's needs, and if it's been drawn up as an effective care plan, the patient or the impacted or infected person would be party to that, so they would be collaborating in developing that care plan and identifying their needs, because as we said before, they are the experts in terms of their physiological and psychological needs. And so it's important that they are saying to us what it is. And of course, added to that is the medical and the nursing dimension that goes into that as well. But a care plan is useless if you don't have sign-out, sort of collaboration from the person who is going to be impacted on.
I was just going to say very quickly, in terms of adherence or concordance, which is a phrase that we prefer, where people are part of their medical treatment, you're much more likely to get people to take their medication more regularly, you're much more likely to get people to follow recommendations for physiotherapy or anything that you ask somebody to do. If they have created a co-created care plan, then the chances of that happening then are much, much higher than if you don't have one.
The next question is about psychological impact again. And it's this. Would you expect there to be an additional adverse psychological impact for someone who has been infected as a result of treatment that wasn't for a life-saving event, but may have been treatment that wasn't essential or even appropriate because they'd been misdiagnosed or because they were, for example, a mild haemophiliac for whom other treatment methods were well established? Is there an additional sense of injustice or harm that people in those situations might experience?
I don't think there's any direct evidence on that, because that was something I was interested in, and it was brought up by one of the questions you gave us. Off the top of my head, one would say yes, it is most likely. But as we said yesterday, with additional problems, you don't necessarily get additional or some sort of linear psychological impact. So terribly difficult to answer. My sort of gut from what I read and what I've read around it is, yes, you would expect that because of the sort of shock and all those other issues that came out of something that was possibly unnecessary.
And then, again, we explored yesterday a number of different psychological and indeed psychiatric impacts arising from illness and treatment and so on. Does the risk of those impacts also include the risk of other harmful behaviours such as addictions or behavioural issues?
We certainly heard that from some of the witnesses, that, because we talked about illness having an impact on, one's sense of oneself and so on, and how one deals with that, and the ways in which one deals with the sort of demands that are on you now can vary hugely on this sort of heading of what we call coping. So, a large amount of coping is attempting to sort of deal with things directly, but a lot of coping is around dealing with things that actually you can't change, or you can't prepare yourself, or whatever. It's out there, it's some enduring problem. And I think a lot of people go for a sort of an avoidant type of coping, which might involve blanking oneself off, turning towards alcohol, turning towards comfort eating, turning to whatever it is, just to avoid that awfulness that's in you, and it's all part of that avoidant coping that we talked about that can be potentially very harmful in the long run.
Dr. Thomas, yes.
Yeah, just that's all right. Yeah. And there's this existing literature, nice guidance suggesting that people with physiological long-term health problems, so chronic health problems of haemophilia, hepatitis C or HIV, already have what we call, they're more twice, if not 3 times more likely to be psychologically depressed. So this is the against the background, and many people are not necessarily aware that they're depressed, but there's a low level of depression that's there. And some people are really quite severely depressed, which then interferes with people's motivation, ability to live life. Then they might turn to other means of coping, like drugs and alcohol and so on, and as a way of coping. But I think it's something that when I was doing this work, I was thinking really that people are already compromised because of having to cope with 2 long-term conditions.
I think we mustn't forget as well that the things that we are dealing with are also extraordinarily painful. So we're dealing with haemophilia, which can be very painful for men, for women with von Willebrand's. We know there are people with haemophilia who are women as well. These are very, very, very painful situations. HIV also can be a very painful, debilitating illness, the treatments that go with that. Then you've got your hepatitis C treatments that coming on top of that. There's an enormous amount of treatments. Drugs and alcohol take some of that pain away, as well as the psychological pain. It would be very unsurprising in many ways that people don't turn to those methods of relief.
And then moving on to the theme of communication, some of the evidence we've heard suggests that people were given their diagnosis or information about their diagnosis either in a group setting or in a non-confidential setting of some other kind, something being called out across a corridor or a clinic. Is that appropriate? And what are the psychological consequences of it?
I don't think any of us even need to answer that directly, but just, I mean, I was totally shocked at the number of reports that we read where people had been told what had to be life-shattering information in the most callous, insensitive manner, with a total lack of privacy. I mean, to be told the sorts of information, particularly as we also have the backdrop of, the stigmatisation, the lack of knowledge about things such as HIV/AIDS and Hep C at the time. To be told that in a corridor, to be told it on the telephone by a receptionist in a GP surgery, that just violates every principle of common decency, let alone sort of how medical professionals should behave. And I think this is starting to feel like question time. The other thing, actually, on a serious note, that I feel sort of is really important to sort of say here, and that is that we've already mentioned that part of the process of coping with a serious diagnosis that's got prognostic sort of implications, total lifestyle implications for you. Part of the thing that we should always do to help people is give them some warning. Fire a warning shot. The realization that you have a life-changing diagnosis, that you're going to have expectations, sort of no longer realize that you're going to need lengthy treatments, and a lot of this might never get better. That's a process, and it needs to be done over time with the right pacing, with the right sort of information at the right level of complexity for the person in front of you. And no one should ever be told a serious diagnosis like this, by somebody just who happen chance to come across the information. People lying on trolleys in an A&E department being told, oh, I think we're dealing with full-blown AIDS here. I think I remember reading one transcript. That is just utterly, totally unacceptable. And I'm sure that no one could ever forgive somebody who did that to them. And you will find, certainly in the world of cancer, which is primarily my area, people will recall verbatim the words that somebody used when it was done insensitively. Bad news is always bad news. You can't make it good news if it's bad. But the way in which people receive it is totally dependent on the person who's actually giving it.
So I'm going to turn my back and see whether there are any other pressing matters that legal representatives would wish to have raised. And no one, I'm happy to report, is popping their hand up. So those are the questions I had, sir.
Well, I have one, but it's a question which is addressed, although I'm putting it to all of you, it's one which you may prefer in due course to answer individually. I'm not asking you to answer it now, for reasons which I shall explain. You've given a lot of thought and a lot of suggestions, and you've demonstrated a number of important changes that there might be, which would make matters, would improve the health service. It would help to make sure that something like this never happens again. Could you please just think of the single biggest improvement you think could be made to stop this happening again? And secondly, second part of the same question is, I've asked what it could be made, should be made. There may be a difference between those two. But it may be very much an individual reaction to that. If it's a collective reaction, that's fine, but it is your expert views which I'm looking for.
Now?
I'm going to leave that with you, and that can be answered with the supplementary questions.
Okay.
But can I now let you into a bit of a secret? When we were planning, we thought that the evidence overall that you would give would last a little bit into this afternoon, and we're very glad that it did, because we were worried that we might not get full value from Theresa and her availability. I'm very glad to say we have done. But the reason it's gone on beyond the 6:30, sorry, the 16:30, I better not think too late, that we've had is because it has been so valuable. And indeed, leading counsel said to me at the last break that she might go on, but I was very happy that should be the case, because I think it's unlikely to be any one of us who has not found your evidence riveting, not found it resonant with many people who are here. It has certainly added a dimension to the evidence that we've heard over weeks from and about those who have been infected or affected by the infection of others. And when it comes to communication, you have demonstrated how it should be done in your own way. So can I thank you very much for that. You've shown us as well, I think, the proper place of your expertise. It isn't an add-on. It certainly isn't airy-fairy, as one of you put it earlier. But it seems to me that you've made the most powerful case there could be for it being an integral part of care, because it meets a need, not just a need for just that sort of care. For those, and you've emphasised this too, for those who want to take advantage of it, because you've emphasised the importance of choice. Can I thank you enormously for that, and all the more so because I know that you have busy lives. I know that, for instance, and I'm singling out one only because the same probably applies to all of you, But Professor Christie, this is her day off, would you believe? And this is how she spends it, instead of with her 2-year-old grandchild. So that is a sacrifice, I can tell you.
Am I allowed to say that, for me personally, it's been an enormous privilege to have been part of this process, and I would like to thank everybody for allowing me to have taken part in this. I've been really, really moved, and it has been a tremendous privilege, and I feel very inspired.
Well, the privilege is ours. Thank you.
Thank you.
Well, Miss Richards, tomorrow,
Hepatitis, sir.
and it's 10:30.
10:30.
That'll be